In three, two, one. Please start, sir. We are live.
Good evening, everyone. It's my pleasure to welcome you all for today's scientific meeting. We are honored to have Dr. Srivatsan sir, uro-oncologist from Apollo Proton Cancer Center, Chennai. And Dr. Srivatsan sir will be presenting on the topic from MHSPC to MCRPC, can we delay the inevitable? An important discussion focusing on optimizing treatment strategies and improving long-term outcomes for patients with metastatic prostate cancer. Without no more further delay, and over to you, doctor. Please, sir.
Thank you. Let me just share my screen.
Yes, sir.
Yeah. Are you able to see my
Yes, sir.
screen?
Yes, sir. Yes, sir.
Thank you. Right. So the topic for the day is from MHPCC to MRCRPC. Can we delay the inevitable? So basically, what we are trying to say here is what is the natural history of the cancer prostate disease, and is there something that we could do to change the spectrum of the disease? Now, why are we worried about that is because the minute we start ADT in a case of a prostate cancer, whether it is localized, locally advanced, metastatic, and so forth, and most of the patients who come to our OPD will be a metastatic hormone-sensitive prostate cancer, or what we call as MHSPC. Now, the day we start ADT, what happens is that we start a chain of reaction that will end up in the cancer cells either becoming resistant to the ADT, what we call as castrate resistant, or they will find multiple other pathways in order for them to escape the ADT phenomenon and thereby grow beyond, or in fact with the help of the ADT itself to grow beyond the cancer spectrum. And that is one of the reasons why we are worried about starting ADT in patients with CA prostate. I know orchidectomy used to be a surgery of favor at most of the centers, even some centers even today, but that has to be abhorred because the minute you do orchidectomy, you've already started the process of eliminating the cell lines which are sensitive to the ADT. At the same time, you enhance the cell lines who are not sensitive inherently or during a course of ADT, turning resistant to the ADT, and thereby we fester into a disease called as a CRPC, or castrate-resistant prostate cancer. And that is the reason why this topic is very, very crucial and very, very important. So we all know that the standard of care for any HSPC is ADT, and now currently we have become like ADT plus being one of the standard of cares. In fact, nowadays ADT plus plus, or what we call as a triplet therapy, is the current gold standard in all indicated patients as well. There is no role of intensification with docetaxel alone, as demonstrated by piece 1 and Harrison. So initially, docetaxel used to be one of the standard of care of this thing, but we have found that the addition of docetaxel does not improve the overall survival per se. So this was the early intensification strategy in MHSPC, which was the addition of docetaxel, both in CHARTED and the STAMPEDE and the GETUC trials. We see that the p-value is not very significant in most of the trials. So that is one of the reasons why we are worried about adding docetaxel alone. Doesn't add much benefit to the patient. So if you go to the guidelines part of it, this is the EAU, which we as urologists and uro-oncologists follow. So we have the M1 prostate metastatic cancer. Either we do a continuous castration or we do an intermittent ADT. If they have adequate life expectancy, then we go the differentiation into the low volume or the high volume disease. Now, there are various criteria by which we do that, either the charted criteria or we do what is called as the STAMPEDE criteria. Now, when they are eligible for docetaxel or not, so we give a a double combination, whether it's an abiraterone or apalutamide or enzalutamide along with ADT, or a triple combination where we add docetaxel to the ADT as well. Now, this is how we have progressed over the years, and this is the EAU guidelines that has been kept. Now, which patients with MHPC they differ from docetaxel? If you see the systematic review and the meta-analysis of individual participant data from randomized trials, you can see that there is a shift towards ADT plus docetaxel. Now, remember, this is ADT plus docetaxel and not ADT plus ARPA and so forth. And this is very crucial because you can see the chart. It is the high volume metachronous and the synchronous patient, and even low volume synchronous. But if it is too low volume, the addition of docetaxel doesn't add much value to the benefit of overall survival. When it comes to the T stage and 1 to 3 and 4, you can see the maximum value is being obtained in stage 4 and not in stage 1 to 3 that much. So currently, if you consider the gold standard, it is the ADT plus with one of the ARPA, irrespective of the timing of the metastasis. What do they mean by that? It can be either synchronous or metachronous. That is, whilst you are evaluating and treating the patient may develop a metastasis that is metachronous. Whereas if at the time of the identification of the disease itself, if you find multiple or a few metastases, it is called as a synchronous metastasis. And this will be stratified according to the risk, volume, and burden, and the co-administration of docetaxel. The addition of radiation is dependent on the volume and the response. If it's a low volume and a good response disease, then we would add radiation to the primary, thereby enhancing the value of cytotoxic therapy to the primary origin of cancer. There is role of intensification with docetaxel alone, as we have already discussed. Now, Arasens trials was the only study which was prospectively designed to investigate the combination of darolutamide with ADT with docetaxel in MHPC. This is a well-designed prospective study in which almost 1,306 patients were enrolled, of which they were randomized 1:1, half of them going into the docetaxel along with darolutamide, 600 mg BID, or ADT plus docetaxel alone. The final analysis was conducted after 533 deaths. Basically, the primary endpoint was OS. I think the OS mature data has also been released of the Arasens trial. And the secondary is what we call as the surrogate markers for these drugs, because it takes a very long time for a CA prostate patient to die. In order for us to get a true value of the CA prostate drug therapy and to bring the drugs earlier into the market, we have secondary endpoints or surrogate markers, which is time to castrate resistance, time to pain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal event or the initiation of a subsequent anti-neoplastic therapy, which is a very important step, I would say, time to worsening of the physical symptoms of disease, time to initiation of the opioid use for more than 7 consecutive days, and the safety profile of the drug as well. So these were all the points that were taken into account during this Arasens trial. Now, the only other trial which compares the ADT triplet therapy was the PEACE-1 trial. Sadly, it was an older trial. It was not prospectively designed to investigate the combination of abiraterone and prednisolone with docetaxel. It included de novo M1, recurrent M1. Prior chemotherapy was excluded, and the recurrent M1 was excluded, sorry. And it included both high and low volume as well. If you see into there was less than 3 months of ADT prior to randomization. There was no prior cytotoxic therapy. The stratification was done according to the ECOG as well as the metastatic size. So the arm A was the standard of care. Arm C was the SOC plus radiation, whereas the arm B was actually the therapy with the triplet and the docetaxel as well. So the PEACE-1 is an open label study with 2:2 factorial design that was only conducted in the European Union, and the primary and the secondary endpoints are very, very similar to that of the Arasens as well. So PEACE-1 was amended to allow for evolving standard of care with docetaxel. So 2013 to 15, it was ADT alone. 15 to 17 was docetaxel because of the recommendation at that point of time. And then 2017 to 18, docetaxel became mandatory as a part of the standard of care. In Arasens, all the 1306 enrolled received docetaxel, whereas this is a fragmented data of additional patient being added onto the study. So darolutamide is the only ARPI which has been prospectively tested and proven in combination with the docetaxel plus ADT to prolong survival and delay disease and pain progression for patients with de novo and recurrent MHPC. So this is the comparative tabular column between Arasens and PEACE1, and we can see that this is a recurrent and de novo MHPC, whereas this is a de novo. The primary endpoint was OS, whereas here it was OS and RPS, PFS. Stratification data is already discussed, and the pre-planned docetaxel, which was given in all the patients, whereas it was evolved during the study period as well. So in the Arasens, we can clearly see the separation of the curves from the start itself, almost from 6 to 7 months. You can see the separation of curves with the darolutamide having a better control. So 63% compared to the 50% with the placebo alone. With the addition of the darolutamide, the 4-year survival rate increased from 50 to 63%. The validity of the early treatment intensification with the combination supported by the result. You can still see the separation of the curve, though the intensity of the curve separation is not so high. You do have significantly improved OS compared to only docetaxel. There is reduction of 25%. Unlike in PEACE1 in Arasens, there was an early separation of the curve, whereas the line remained separated over the time, whereas here it is a delayed separation and not a big separation between the curves. The patients in the darolutamide arm stayed on the treatment 2 years longer than the patient in the placebo, which is a surprise because placebo is supposed to be not a great tablet to take. It is a simple, paracetamol or some things like that. Still, the patient was more so on darolutamide. It clearly indicates the side effect profile of the drug, we're able to tolerability of the drug for the patient as well. So the darolutamide here, you can see that compared to the follow-up was more. Whereas in the abiraterone and steroid, which is given along with the abiraterone, there was a rate of discontinuation due to the side effect was higher, the abiraterone arm. Darolutamide did not affect the ability to complete the full cycle. There was not much side effect profile, which led to the discontinuation of the darolutamide, whereas abiraterone had to be discontinued a little bit due to the side effect profile of the combination therapy. So in Arasens, the incidence of any grade was similar in both the arms. In fact, grade 4 and 5 was not that many as well. In PEACE1, whereas the grade 3 and above adverse effect was higher in abiraterone plus docetaxel, is a combination of steroids as well as chemotherapy led to a lot of side effects, including hypertension. Sorry. In Arasens, the incidence of adverse events of interest were generally similar between the treatment arms. You can see that the percentage of patients of fatigue and everything was almost very similar. Incidence of rashes and hypertension was higher in the darolutamide when compared to the placebo arm. That is a grade 1 to 2 adverse events as well. So coming to the treatment per se, the SOC for any MHSPC is ADT plus one of the ARPAs, irrespective of the timing of the metastasis, risk, volume, and burden, and with the co-administration of docetaxel. We should remember that the docetaxel starting should be less than 6 weeks after the initiation of the therapy. Anything more than that cannot be considered as a triplet therapy as well. There is no intensification role of docetaxel alone. It has to be along with an ARPI. In patient with high burden, the chemotherapy fit, do you recommend the triplet therapy? Yes. 94% recommended the triplet therapy, and most of them chose the darolutamide as well. In synchronous or asynchronous disease, still, if the patient is fit, then the triplet therapy is the standard of care from now on. So when do you not give triplet therapy and when do you choose doublet? It depends on the status of the clinical status of the patient as well as the tolerability and the side effect profile. So pill burden, exacerbation of ADT, adverse effect, and CV, cognitive bone health. If the patient is not too amenable to this, then we start with doublet. Otherwise, we always give a triplet therapy. So coming to the take-home messages, there are 2 studies that are currently available with triplets. This thing, one is a well-defined and well-randomized Arasens, and the other one is the PEACE1. And it's very clear that in both the studies that triplet is the standard of care from now on for the metastatic HSPC in fit patients. And of both the studies, Arasens stands a little apart with showing the darolutamide addition to the therapy adds value in both overall survival as well as in all the secondary endpoints that it was designed to represent, and to proactively manage adverse effects of new treatment option and to optimize treatment outcome. Multidisciplinary care, obviously, in addition to the medical oncologist, we also, treat the cancer along with the medical oncologist with docetaxel. All eligible patients should be offered the benefit of all proven effective treatment to enable living with preserved and improved quality of life. Thank you.
Thank you, Doctor, and thank you very much for your insightful and informative presentation. We truly appreciate your time during your busy schedule. You are attending the meeting, sir. Actually, sir, we have some questions in the chat box. I hope you are seeing that, sir.
Yeah, with increasing use of PSMA PET, have you observed changes in treatment decision? Would previously been classified as low volume or conventional? So yes, I agree. Most of this trial, especially PEACE-1 and even for that matter, Arescence, I think added a PSMA PET as well. So conventional bone scanning and CT scan was used as a imaging modality. But I think with the evolution of PSMA and our experience with PSMA PET for more than 10 years, I believe that currently PSMA PET will be, so we're picking up more and more oligometastatic disease and metastatic disease, which would have been missed by conventional imaging. So what would have been classified as a, what we call as a, non-metastatic disease is now being classified as a metastatic disease, and more, driving of the stage 3 and stage 4 as becoming more with PSMA PET scan. Now, coming to the sensitivity and specificity, PSMA PET has proven its worth by being quite sensitive as well as specific for PSA, for cancer prostate. And I think that is the way to go forward. There is no second questions asked about the utility of PSMA PET scan in the diagnosis and the treatment of CI prostate.
Thank you, Doctor. I think one more question is also there in the chat box, sir.
The patient starts ADT alone and presents a few weeks later. How do you still escalate to triplet, and what is your practical time window? So the practical time window is somewhere between 6 to 8 weeks. If the patient arrives to us after starting ADT within this time period, I think there is always a good opportunity to escalate it to triplet. However, even if they come late, doesn't mean that we avoid the start of a triplet therapy, but that also tells us that we are not on the classical definition of triplet, but we could still offer the triplet therapy. The benefit, I don't think, would be much different if you start immediately and after. So on classical sense, you cannot call it as a triplet therapy.
Thank you, Doctor. Thank you very much for your active participation and engaging discussion. We sincerely thank you, sir. And we hope today's session has provided valuable clinical insight that can be benefit or practice. Have a wonderful evening and stay safe. Thank you, Doctor. Thank you very much, sir.
Thank you. Thank you so much.
Good day to you, sir. Tech team. Tech team, can you hear me? Tech team? Tech team, can you hear me?
Yes, sir.
Yeah, we can end the meeting now.
Yes, sir. Okay. Thank you.
Thank you.